How do doctors figure out what's wrong with you? It's through something called the differential diagnosis. Let's get into it. What's up, everyone? Mike Muellner here. I'm an internal medicine doctor from Los Angeles, California, and today we're going to talk about the differential diagnosis. So you've probably seen medical shows like House, where you get all the different doctors standing in front of a whiteboard and they're all writing out potential explanations for a patient's symptoms. So what they're doing is they're forming a differential diagnosis. They're thinking about all the different potential diseases that could explain a patient's symptoms. And it might seem kind of random, or sometimes it just seems like a bunch of scientific mumbo jumbo that just flies over your head. Even in my case, I've been practicing medicine now almost 10 years. Sometimes the illnesses that they treat on that show are so esoteric, so unusual that I don't even quite follow what's going on. But in any event, forming a differential diagnosis is very important as a roadmap to figure out how you're going to eventually come to a conclusion as to what's making a patient sick. So here's how it works. Let's say you got a patient who shows up in the emergency department with a complaint of chest pain. So immediately when I hear that word, I start thinking about different diseases that can cause that. And in essence, I'm already starting to form a differential diagnosis. But as I talk to the patient more, I want to get more details. So I'll ask, when did this pain start? Exactly where does it hurt? Does it radiate anywhere? What does it feel like? Is it sharp like a knife stabbing, more of a dull pressure sensation? Have you ever had this pain before? And so I get a little more details. And as I'm asking those questions, I'm already thinking about different potential causes of chest pain. And based on the answers to the questions, certain causes will become more likely, other causes less likely. Just to give you an example, acid reflux, that's a common cause of chest pain. So if the patient's telling me that, oh, I get it after I drink coffee and I lay down at night, that's when I get this burning sensation here, then I'm going to think acid reflux is maybe a little higher, a little more likely. And then some of the other potential causes of chest pain, for example, heart attack, that's a big one, that might start to seem a little less likely. And so that process already gets started just when you're asking questions. Then after the initial interview, I'll take into account a patient's prior medical problems. Do they have risk factors for cardiac disease like high blood pressure, diabetes? Have they ever had a heart attack in the past? The answers to these questions will also help to raise or lower different potential diseases in my differential diagnosis as far as which ones will be more likely or less likely. Then I move on to the physical exam. So this always starts with vital signs. Vital signs are your temperature, heart rate, respiration rate, and although not technically a vital sign, but also oxygen concentration is another thing we look at. And from there, moving on to the physical examination. But a thing on the vital signs, sometimes even just the vitals can cue you into certain diagnoses. For example, if I see that the heart rate is very fast and the oxygen is low, then when I've got somebody with chest pain, I might think this could be a blood clot in the lung. And that makes that potential diagnosis move up higher on the list. So then onto the physical exam, it's important not to get stuck just looking at one organ system. So if you hear the word chest pain, you might think, oh, it's going to be something with the heart. I'm going to listen really carefully to the heart, and then everything else not as important. But that's not the case. You want to go do a full exam head to toe, make sure you're not missing anything, because during the exam, you can pick up clues which might help you narrow your list of potential diagnoses. For example, if you're listening to the lungs and you hear some crackles, that might make you think maybe there's some fluid in the lungs. This could be congestive heart failure. Or when you're feeling pulses, if they're not symmetric, you can feel a pulse on one side, can't feel it that well on the other side, you might think, could this be an aortic dissection or a tear in the big artery coming out of the heart? So little things that you can pick up during the physical examination. So now after that, you've done your interview, you've looked at vital signs, you've done your physical examination. This is when I really sit down and start to form a formal differential diagnosis. So to use this, I use the SPIT mnemonic. So S stands for serious. I think about all the serious or potentially life-threatening explanations for the patient's symptom. In this case, chest pain. I would think about heart attack. I think about blood clot in the lung or pulmonary embolism or aortic dissection. Then P stands for probable. So here I look at causes that are really more common. Even though they might not be as serious, there's stuff we see all the time. So acid reflux, that's one explanation. Or chest wall inflammation, we call this costochondritis. That's another potential cause of chest pain. And then finally I, that's more interesting causes. So these are very rare diseases. We call them zebras. Hardly ever see these. These would be things like, for chest pain, Liebman-Sachs endocarditis as a sequelae of lupus, a more rare cause. And finally, T stands for testing. So you start to think ahead of time, what kind of tests will I need to do at this point to help narrow down the diagnosis? So now that I've formally made my differential diagnosis, I've thought of very serious causes of the patient's symptoms. I've thought of more probable causes, and I've thought of a few zebras, I start the process of narrowing down the differential. So right off the bat, what you don't want to do is just focus on one thing and then forget about everything else. You don't want to hear, oh, it's chest pain, a young person, happened after a meal, it's probably acid reflux. I'm going to turn my brain off, I'm not going to worry about anything else. No, that is an absolute trap. You don't want to do this. Now, sometimes it happens if you get multiple doctors. So if a doctor sees a patient and then forms his or her own diagnosis, it can be easy as the second doctor who's seeing the patient next to get stuck on that initial diagnosis. We call this framing bias. And so that's another way where you can really get stuck on something too early. So you want to try to resist that. The other thing you don't want to do is go zebra hunting right away. Even though it would be fun to chase after very unusual diseases, in most cases, that's just going to be a waste of everybody's time. You're going to cause a delay in making the actual diagnosis. It can even put the patient through unnecessary tests, some of which are invasive, things like biopsies, and it can waste resources. I mean, a lot of these tests, like for cardiac amyloid, you might want to get a MRI, a specialized cardiac MRI scan. It's very expensive, costs thousands of dollars, and requires a skilled radiologist to interpret it. And in most cases of chest pain, wouldn't really be helpful. So that's what you don't do, but what do you actually do? So you start narrowing down your potential diagnoses, starting with the most probable and most serious ones first. So right off the bat, you hear chest pain in a patient who might be older with cardiac risk factors. Immediately you want to get an EKG. So an EKG, or electrocardiogram, looks at electrical impulses within the heart, and you can pick up subtle clues that there might be something like a heart attack or an arrhythmia going on. Also, for somebody whom I'm considering a heart attack, I'd be very quick to order a troponin. This is a cardiac enzyme. It looks at a breakdown product of heart muscle, which will be elevated in somebody having a heart attack. But I don't want to get stuck on just one diagnosis, so I'll also order a few other things to check for some other potential causes of the chest pain. For example, I'll get a complete blood count. This is a blood test where I can look at the white blood cell count. If it's elevated, I might be more worried about infections such as pneumonia, or the hemoglobin is also shown there. This is a value that will be low if there's any bleeding anywhere. I'll also get a metabolic panel. So this looks at kidney function and electrolytes. If there are electrolyte abnormalities, like let's say potassium is very elevated, I might be worried that there could be an arrhythmia going on. Or if the kidney function is down, that could be an explanation for crackles that I hear, which could be a sign of fluid in the lungs. Then I'll consider any imaging tests. One that's commonly ordered in the emergency department for workup of chest pain is a chest x-ray. So you might think, why do you want to get a chest x-ray? That doesn't look at coronary arteries. That can't tell you if there's any blockages or a heart attack going on. The heart might very well look normal in a chest x-ray, even in somebody who's having a massive heart attack. Well, you get it because you're looking for other things. You're looking for things like a pneumothorax, part of the lung deflating. You're looking for evidence of pneumonia, changes in the mediastinum or the area around the heart. If it's widened, you might be more concerned for potentially a aortic dissection. And finally, moment of truth. We've collected all our data. It's time to put it all together and arrive at the most likely diagnosis. So let's say in our patient with chest pain, it was chest pressure radiated to the left side of the chest, and the EKG showed some changes. In particular, it showed ST, we won't say ST elevations, that's already definitely a heart attack. We'll say ST segment depressions. And then on our blood test, we looked at the cardiac enzyme troponin, that was elevated. Other tests like the complete blood count showed that there was no elevated white blood cell count, no unexplained anemia. And so that's going to put the infectious causes lower on the differential. And finally, putting it all together, we have chest pain where acute coronary syndrome is highest on the differential. And so what we'll do is we'll tailor further testing to evaluate for this. For example, the troponin level, we'll definitely trend that throughout the night, see if it rises higher. But then if the diagnosis isn't 100% clear, you can still say also on differential would be acute pulmonary embolism, but this is less likely. There's no hypoxemia. The oxygen level looks good. Even lower still on the differential would be an infectious cause such as pneumonia. There's no fever, no cough. White blood cell count is not elevated, and so on and so forth. And so there you go. That's the differential diagnosis. It is kind of a long, complicated process. I definitely made this video off the cuff. I don't have a script or anything, so hopefully this is going to be coherent. But I hope you enjoyed this video. I hope it was informative. Here's another video you can check out here. And if you like these videos on medical content, healthcare related content, go ahead and hit the subscribe button, and I will see you guys next time.